and good afternoon. I'm Catherine Santoro, Director of Policy and Development at the National Institute for Healthcare Management Foundation, and I'm very pleased to welcome you today to this webinar, Improving Access to Integrated Palliative Care. Palliative care is one of the fastest growing areas in healthcare, yet access to palliative services remains variable, and there's a general lack of integration with those providing medical care for patients facing serious and chronic illness. Moving to a payment model that recognizes and encourages team-based, coordinated palliative care is no easy task, but it is essential to lowering costs and improving both quality of care and quality of life, along with reducing emergency department use and hospital admissions, as well as their associated costs. Today we're joined by an excellent panel of leaders who have been at the forefront of increasing access to coordinated, high-quality palliative care across the United States. Before we hear from them, I'd like to quickly thank NIHCM's President and CEO, Nancy Chalkley, who led the development of today's webinar, as well as the NIHCM staff who helped to convene this event, including Katie McDonald, Carolyn Myers, and Amanda Parker. For our audience, you can find biographical information for all our speakers, along with today's agenda and copies of their presentations on our website, www.nihcm.org. I'm now pleased to introduce our first speaker, Senator William Frist, a nationally acclaimed heart and lung transplant surgeon, former U.S. Senate Majority Leader, and Chairman of the Executive Board of the health service private equity firm Cressy & Company. He's actively engaged in the business as well as the medical, humanitarian, and philanthropic communities, and he's also a member of NIHCM's advisory board. In recent years, he's been working to advance the field of palliative care, and we're so pleased to have him joining us today. Senator Frist?
Catherine, thank you, and good afternoon to everybody who is on today. I am Bill Frist, and I'm delighted to be opening up this very exciting webinar for the National Institute for Healthcare Management. So let's get started. Palliative care is one of the fastest growing specialties in American medicine today. And the most important factor about all this growth is it is driven by need. Our aging population, combined with the financial shift in medicine from the traditional fee-for-service to more value-based care, has now opened the window for new models that can appropriately care for the chronically ill in a cost-effective yet high-quality way. The current reality is that about 5% of the U.S. population spends 50% of the healthcare dollars. You can see that here on this slide. The people on the horizontal axis, between 95 and 100%, those in the red box, are accounting for over 50% of all of that healthcare spending. And what's interesting is that the people making up this 5% are largely the chronically ill or the actively dying. 5% of Medicare beneficiaries, that's about 1 out of 20, die each year, and their end-of-life care accounts for over a quarter, or 27%, of Medicare spending. Whereas 95% of all Medicare beneficiaries will spend, on average, $4,400 in a year. 5%, or 1 out of 20, at the end of their lives will spend more than $26,000 in that same year. And why does it cost so much? Sadly, in the last 30 years, end-of-life care in this country has been a highway to the intensive care unit and the costly dying or death in the hospital. This whole model that has evolved over the last 30 years is fraught with problems, the least of which is what I started with, and that's the cost, although it's big, and the most important being the the destructive impact it has on the patient and that patient's family and loved ones in terms of quality of that overall end-of-life experience. So what do we do about it? From a cost perspective, targeting this 5% is a potential place for major cost savings. But even more than that, it is the right thing to do. People don't die today the way they'd like to die, and we all deserve a good death. And it's the palliative care model that has evolved over the last 15 years or so that specifically offers that. But targeting this 5% requires identification of people with chronic illness who are approaching the terminal cycle of hospitalizations that will eventually lead to their death, and offering them instead a different, more appropriate, and more satisfying model of care. And we actually can do this, for example, by using modern claims-based algorithms made possible today by sophisticated and modern use of big data, and computers, by physician team partnerships, by telephonic and in-person assessments, among many other models. So there's a huge need for palliative care. But what does palliative care really mean? What is palliative care, and why is it the solution? I love this quote by Isaac Asimov. Life is pleasant, death is peaceful. It is the transition that is troublesome. You know, it's so, so true. But the good news is that Asimov didn't know. He didn't have the advantages of knowing about palliative care. Palliative care makes the transition, using Isaac's words, less troublesome. Palliative care is that optimization of quality of life to relieve the suffering of critically ill, very sick patients at times and their families by focusing on maximizing symptom management to relieve pain and increase comfort. This is done while carefully considering and addressing the emotional and the social and the spiritual needs of the patient, as well as the physical and the family, during the course of illness and after death. What does this really look like? And let's just take an example. Here you meet Alma. She's a 74-year-old woman who is a smoker with advanced chronic obstructive pulmonary disease, type 2 diabetes. She's on insulin, has the initial stages of dementia. Her husband, Jack, is at home and in relatively good health, but is also 74. Both of her children live out of state and are not involved in her day-to-day care. And unfortunately, Alma has started that terminal readmission cycle in and out of the hospital we see so often, and has been in the hospital 2 times in the last 2 to 3 months for shortness of breath, with the last admission lasting 8 days. Each of those admissions is expensive, is taxing, and they are wearing Alma and her husband out. They're exhausting them. Enter the palliative care model. Instead of putting Alma into a cycle of readmission, bouncing in and out of doctor to doctor and hospital to hospital, we put Alma in the center and bring the resources to her and to her family. And not only does she benefit from things like 24-hour telephonic monitoring, but her outcomes, her experience will improve as well. And that's an evidence-based assertion that we know today. This article from the New England Journal showed increased quality of life scores in patients in a palliative care program. They also showed 58% less depression, 39% less aggressive end-of-life care, with aggressive end-of-life care defined as chemotherapy within 14 days prior to death, and longer median survival times, almost 12 months versus 9 months. And that cost issue that I started with, we've also shown all of this reduces cost. This article from the American Journal of Managed Care presented a randomized controlled study of palliative care model as applied to a patient cohort that largely carried an oncologic diagnosis. The group randomized to palliative care had 30% fewer emergency department visits, 38% fewer hospital admissions, and 2 years more life expectancy. And this all happened at an $18,000 per patient per month lower price tag. And the secret is in moving the locus of care to home. Palliative care seeks to be patient-centered and deliver care where the patient is most comfortable and most familiar and most secure, resulting in better outcomes while at the same time being more cost-effective. This slide shows just that. A palliative model reduces hospital days while increasing home health visits in its place. Now, I want to show you something fascinating to further make this point. The first slide is from the Dartmouth Atlas, well familiar to all of you, and looks at the number of hospice days per region. The dark areas on the slide mean more hospice days. I'll come back to this slide shortly here, but just take a look at it and look where the dark areas are. Now look at this next slide on inpatient dollars spent. This is where inpatient dollars are spent. Again, dark means lots of dollars and light means fewer. These two slides are almost the exact inverse of each other. Let me go back and show you once again these two slides. Let's flick to that next slide. Hospice days used in the last 6 months, and then once again the inpatient spending, the inverse. So having discussed the problem and the solution, let's put all this together and talk about the huge opportunity before us. The three models, really three major models, if you have to have three big buckets out there today addressing it. One would be similar to a Aetna Compassionate Care, who uses a telephonic case management program focused on patients facing a terminal illness to improve the outcomes and decrease hospital admissions. A second example of a different model would be that of Kaiser Permanente, and they actually providing home and hospital and clinically based palliative care to their customers at a capitated price. The third model would be a company like Sutter Health Advanced Illness Management. They connect 24 hospitals and over 5,000 physicians in Northern California to bridge the gap between acute care and end-of-life care for Medicare patients using a more traditional fee-for-service model. Now, all three of these are successful, and an examination of their model reveals several commonalities. First, they all show strong leadership and vision. Secondly, they use sophisticated, modern information technology systems and electronic medical record. Third, they have achieved physician buy-in, absolutely critical, by framing the service as additive to their physicians, not replacing them, not supplanting them. Fourth, they use a capitated or a value-based payment system to reward providers who actually reduce inpatient care. And fifth, they have a patient and family-centered approach, like that graphic that I showed earlier of Alma, smack dab in the middle of that team-based approach. And finally, they're using palliative care physicians, people trained, specifically trained in end-of-life care. The truth is, in a palliative care setting, the goal is improved quality of life, which means better symptom management, reduced episodes of acute illness, and overall better patient well-being. And the only way to achieve this is through a coordinated, seamless medical team model. So, of course, you ask if value-based care in the palliative setting means coordinated care, and the outcomes achieved are clearly cost-saving, why in the world isn't everybody already moving to this model? And the reason is the same. Current reimbursement models simply do not support it. We bill for procedures, not outcomes, and even the shift to paying for outcomes is physician-centered. Chaplains and social workers, which are imperative to overall good, excellent care, especially when you're dealing with physical, mental, emotional, and spiritual health. But they don't, in turn, generate a revenue under the current model, so the current model must be changed. What are the barriers? Specifically, we're facing a host of barriers. Some are regulatory and others are out there in the market. First, on the regulatory side, the Medicare statute, the Social Security Act, has been interpreted to exclude supportive care like that provided by most members of a palliative care team because coverage is limited to interventions that improved health only. The actual quotation is, care is covered unless, and these are the exact words, not reasonable and necessary for the diagnosis or treatment of illness or injury or to improve the functioning of a malformed body member. Those are the words out of the Social Security Act. However, the light at the end of the tunnel are that the Medicare readmission penalties of the last couple of years for patients who are readmitted within 30 days for certain conditions, and those conditions are heart failure and heart attack and pneumonia, all of a sudden gives us a new opportunity to reform and to shape reimbursement. Additionally, the Center for Medicare and Medicaid Innovation has established programs that fund cooperative agreements and challenge grants which aim to demonstrate this integration of supportive care with traditional medical services. So there is some progress on the regulatory side, minimal it may seem, but opportunity is there. Let's flip over to the side of the market forces and culture change, and we're also facing barriers there. We need to address these barriers right up front. Not only must government-sponsored insurance change, but private insurance as well. However, changing payment models, as much as it must happen, is disruptive, especially given that healthcare is a whopping 18% of our gross domestic product. Secondly, there's an issue of physician buy-in. Doctors are used to caring for their chronically ill patients in one way, many times the way in which they were trained and the way they're most comfortable with. And this model, this current model, changes all of that, much more of a team-based approach. Physicians have to have some skin in the game, or they simply are going to oppose it because of their more conservative ways as this change comes forward. We want the outcomes palliative care can offer. We know they're there. We know by applying the system of palliative care, we can achieve both the cost effectiveness, but much more important, that experience and outcomes that we know that the patient receives. We want the cost savings that the palliative care can generate, but to do that, the payment model absolutely has to change, which requires proving to payers with data, with our models, that a medical team approach works, and then finding people brave enough to venture in the palliative space when payment is not guaranteed. Private payers are uniquely positioned to make these changes because they are not subject to the same challenges as those government-funded health insurance. But there is also a unique opportunity for new business models entirely to help influence the system and shape the system of the future. In order for private payers to invest in palliative care, though, payers need to have confidence that care will be delivered in a consistent way that is cost-effective, that is scalable, that produces a positive return on investment. And this is one of the reasons I've teamed up with several people to launch Aspire Health. And as you're going to hear shortly, Aspire is recruiting some of the best palliative care physicians in the country to set up independent palliative care physician practices, and the physicians and practices are building home and outpatient-based palliative care programs focused exclusively on partnering with private payers and accountable care organizations. To support these practices, Aspire has built sophisticated patient identification algorithms and an information technology system that allows us to proactively identify the patients who could benefit most from palliative care and then track the clinical and outcomes data that matter specifically for palliative care patients, and allows us to share these data in an easy, seamless, and reliable way with those patients, primary care physicians, as well as specialists in the health plan. So to tell you more about what we're doing with Aspire, please let me introduce Brad Smith, co-founder and CEO of Aspire Health, and Dr. Andrew Lasher, our Chief Medical Officer. Andrew, why don't you take it from there?
Thank you, Senator Frist. My name is Andrew Lasher. I'm the Chief Medical Officer of Aspire Health, and as Senator Frist mentioned, Brad and I are helping set up, basically think of it as a series all over the country of house call physician practices for really sick patients. That's how we talk about Aspire. What we're doing is, as you mentioned, is partnering with some of the best palliative care physicians in the country to provide a service that really hasn't existed up until this point in the private sector. My career in palliative care started, like a lot of people, in the intensive care unit, where I was noticing this just endless stampede of really, really sick patients who were clearly suffering, clearly at risk of coming in and out of the hospital, and often they were winding up in the hospital or the ICU as the very end stage of a terminal illness. When I started thinking about a career in palliative care, it was 2001, and it wasn't clear that there was going to be a career at the end of that rainbow. And it's a real credit to folks like Dr. Meyer, who's on this call, that the profession itself has grown to the extent that it has. But like most young palliative care providers then, I really had a choice between practicing in a hospital or practicing in a hospice. And as it turns out, I did both. But in the hospital, setting up inpatient palliative care programs in Northern California, I was actually with the Sutter Advanced Illness Management Program. You just began to realize that all these folks that we were seeing, these patients with cancer, with heart failure, with COPD, dementia, we were seeing them way too late. And you ask a palliative care provider, when is the ideal time to see a patient? It's clearly at the time of diagnosis, or at very least earlier in the course of an illness than what we were seeing in the hospital. And that's why I became so interested in programs that could see patients not at the point of crisis close to the end of life, but to see people earlier. So these patients where if you ask the question, would you be surprised if this patient passed away in the next year? People with cancers, heart failure, dementia, end-stage kidney disease, seeing them not in the hospital, but in the home setting or the outpatient clinic setting, when you can make a bigger intervention on their quality of life, their physical symptom management, emotional and spiritual symptom management, and potentially help break that cycle of hospitalizations so that people's care can really align with their values. So many people say they want to be at home as they get sicker, but so few people are. And what Brad and I are seeing is that if you can identify the right patient earlier in the course of their illness, intervene in the home, as we'll explain how we do, and provide that symptom management, that good care planning, that good care coordination, then people will feel better, they will live longer, and yes, they will cost less. And all of those things, I think, are very positive for the system, but more importantly, very positive for patients and families. And with that, I'll hand it back to Brad and let him walk through a little bit more of our model.
Thanks, Andrew. What Aspire, just as Andrew said, has really been focused on is helping stand up this group of palliative care practices and really doing all the things that you have to do to be able to take something like this to scale. What we saw across the country was really that the palliative care outpatient models that were out there, they were all really scattered and vastly underfunded. You saw lots of, especially nonprofit hospices that would launch these programs for a year or two on a grant, sort of understaff it, but have some services. The grant would go away, the program would go away. And so what we're really trying to build is sort of a scalable solution. So part of that, as we'll talk through, is about it being able to identify the right patients. What we know is if we offer this intervention for the right patients, it not only benefits them, but it also is a cost-effective solution for their health plan partner or their ACO. But we knew to build this, we really needed local market leadership. So we're going into each market across the country and recruiting the very best palliative care physician in that market to run these practices. And I think that the reason that we found those partnerships to be really strong is I think the palliative care physicians are looking for a partner who can help them set up a system to be successful. But for us, having these relationships in the market where they know the PCPs, they know the oncologists, they know the cardiologists is really important. And all the markets we're operating, we're investing in additional on-the-ground management capacity. We're building scalable systems like we'll talk about in EMR, a clinical support system, policies and procedures. We're building quality metrics. We're actually integrating with the big national database for outpatient and some inpatient palliative care outcome metrics. And we're also proving that there's a good business case for palliative care by being able to take on financial risk and show the return on investment. So what is our model? What we do is we go out and we contract with anyone taking risk. In today's world, that's still primarily health plans, Medicare Advantage, Managed Medicaid, commercial health plans, but also at some provider groups, so ACOs, specialty physician practices. And then we have a number of ways that we partner with them to identify patients. We built algorithms that are specific to MA, Medicaid, duals, commercial. We are going out and doing physician meetings in markets. We built telephonic screens. We figured out ways to leverage other assessment and case management data that health plans have. But with each health plan or with each ACO, we figure out a way to identify patients who we think are likely in need of palliative care. In most cases, we work with their physicians, so their PCPs or their specialists, to make sure that palliative care is appropriate, and then we reach out to the patient. When we reach out to the patient, in most places, it starts with a nurse practitioner visit to the home. It's a comprehensive business. It looks at both clinical, psychosocial, emotional, spiritual needs, and then we're also running a number of outpatient palliative care clinics co-located in large oncology practices. Then we have a whole team that gets involved: nurses, social workers, physicians, nurse practitioners, chaplains that Andrew will talk a little bit more about. We provide 24/7 support, so when a patient calls us, they don't get a nurse triage line. They either get the nurse practitioner or the doctor in their market who's on call that night. And we found that, as Andrew will talk about, that 24/7 piece to be really important to providing high-quality care. And then we have a number of reports that we provide both back to the health plans and back to the PCPs and specialists. But with that, Andrew, do you want to talk a little bit more about the team?
Sure. As Brad alluded to, like any good palliative care intervention, it's an interdisciplinary effort where you're meeting on a weekly basis with a number of different roles, where everybody's responsibilities and roles are delineated, but their stewardship and the input are more shared. That's just sort of a standard feature of palliative medicine. I guess I would just tell a story. So this last week, we had the privilege of both onboarding a new physician in one of our markets in Tennessee, and also hosting this really amazing collection of physicians who are going to be helping us open markets all across the country. And these are people that did all the blocking and tackling to build palliative care as a field: Janet Bull and Martha Twaddle and David McGrew. That in our field, people who are quite well known. It's very humbling to work with. They're all in the office. So our physician in the morning was out with one of our nurse practitioners supervising and seeing how a visit goes. And what they found was a patient with advanced heart failure, very much in the throes of an acute exacerbation. The nurse practitioner had already addressed goals of care for this patient. The goals of care were really clear. It was survival above all else. This was a patient who was in their mid-60s, but had a late in life child who had not yet graduated from high school. Every effort was being made to get this patient better and prolong life with whatever means were necessary. So this involved the nurse practitioner placing an IV, giving intravenous Lasix, scheduling a follow-up visit the next day to check labs, just as you would in a hospital, treating an acute exacerbation of heart failure with all means necessary. And so she comes back to the office, and it turns out that there's a patient so similar in every way except the goals of care that our social worker in the office had developed a relationship with over the last 4 months. Prior to coming on our service, this had been a patient who'd been hospitalized, I believe, 4 times in the 3 months preceding. And now, because the hospice conversation, the goals of care conversation had been opened, this patient having an exacerbation was being transitioned into a program, hospice, where they were going to stay at home and focus exclusively on comfort. And because the barrier to that had been spiritual, an understanding of their responsibilities to stay alive that really weren't consistent with what the patient wanted, our chaplain had also become integral to their care. And our chaplain had gone to that patient's house late in the day to wait for the hospice nurse to be there to open the case. So 2 patients that were similar in every way according to their demographics, their claims data, but the goals of care were different. And I think what it illustrates is that you really need this interdisciplinary team that's responsive and, as Brad said, available 24/7 to respond to a patient or a family's needs. That is really how we try to provide our intervention that helps people stay out of the hospital when they don't either want or need to be there. And all of these roles are so critical for doing that. Brad?
Yeah, and so what we've built to support this team, both the team that's in the field and the team that's in the office, because the team in the field, I would say, acts very similar to a traditional home-based palliative care or in some ways sort of a hospice-ish team. The team in the office acts a lot more like a care management team. And so it's really the combination of these two things that we think is producing the outcomes that we'll share momentarily. But we've also built a couple different tools to support to all these clinicians. One is we've built some patient identification analytics where we can go out and work with health plans to identify the appropriate patients. The chart you see here, so month 0, this is month prior to death, so it's passing away on the right-hand side. This is from a real Medicare Advantage plan. The blue is the health plan's revenue per month, and the red is their cost per month. And so what you see is that to these health plans, the cost is significantly higher than what their revenue is every month. And these are just an example of the kind of analytics that we've built that both help health plans understand and see what their opportunity is, but also help us over time measure the impact that we're having. Another tool that we've built to support all the markets is we built our own EMR. It's focused on palliative care specific assessments, e-prescribing for controlled substance, tracking outcomes data, being able to share data back with health plans. But one of the most important things we do is this report on the right, which is a report that gets produced after every home visit. A big part of palliative care is you want to make sure that you're communicating back with the PCPs, back with the health plan, back with the specialist. And so we actually produce this report, and it goes back to all those parties after every home visit. In certain cases where we have large partnerships, we also build things like API, HL7 interfaces that can push the data directly back into EMRs. So how is this going? What do our outcomes look like? Here you see the enrollment rate. So when we have a patient referred to us, they're coming onto the service about 80-90% of the time. Compared to other care management programs, this number is really high. The reason we think we're seeing that is really the role of our lead physicians in the market. We're recruiting really great lead physicians. They're spending a lot of time building relationships with PCPs and oncologists. And when a patient isn't sure about if this is the right service for them, we're able to circle back with that PCP, maybe the nurse in their office, to reach out and talk with the patient. In terms of the diagnosis we're seeing, it really depends on what kind of health plan it is. This is for a Medicare Advantage plan. All of our patients, our average patient has 2.8 of these diagnoses, so this is sort of their primary diagnosis. But you see it's a range of CHF, COPD, cancer, dementia, end-stage renal disease, different populations. So say commercial health plans looks almost entirely alike, cancer with a little bit of neurological disease. We're doing, not surprisingly, a lot of advanced care planning. In addition to completing a lot of documents, which is what the graph on the left shows, there's a big JAMA study that came out in the spring that said the average advanced care plan gets completed 60 months or 5 years before someone passes away. So good to complete, but by itself we don't think that impactful. So the more important stat for us is the stat on the right, which is, are we engaging in active advanced care planning discussions with these patients at the time when they're likely to have a crisis, and making sure that their family, their PCPs, et cetera, are on the same page, so that while they might not have the crisis yet, they might just be likely to when the crisis does occur, when they call the 24/7 number, we can help their family and the patient deal with it in the way that they want to, just as Andrew shared with the example from last week. We're seeing really good outcomes data. So about 70% of our patients are getting discharged to hospice. A portion of them, 15% or so, die on the service. The ones who are passing away on the service are typically doing so because their goals are not yet aligned with hospice. And so they end up maybe going to the hospital. We've also had some patients that we've helped pass away at home, and that's been their goal. And they haven't wanted to go to hospice. And what we're seeing is when patients go to hospice, not only are more patients going, but they're also going earlier. So with the hospices we partnered, we more than doubled their median length of stay in the hospice, which both provides the patients more care and more support, and also has significant implications for the health plans. In terms of hospitalizations, we've seen a massive decrease with our intervention. This graph's a little confusing, but we've built an algorithm, and so this is data from one of our health plan partners. The middle bar is if you took every patient who hit the algorithm and said, what's their ADK? The left bar is if you took everybody who hit the algorithm and they were the patients who passed away. and on the right is where we are. We think the reality, because we not only use our algorithm, we use additional screens that are based on functional status and other things, it's probably somewhere between this 56 and 72%. But we think, and the health plans we're working with have confirmed, that we're dropping hospitalizations in this magnitude. And for example, the first health plan that we started working with less than 12 months ago has actually rolled us out into 8 new markets already. And so they're seeing really strong internal results. But the whole big part of making this happen and making this be successful has really been building the right team with the right expertise across a range of fields. So it's having leaders like Senator Frist, who are very involved at the policy level, but also people like Mike Tadine, who ran a large care management company called Inspiris that was purchased by United, and somebody like Matt Downs, who runs an investment fund of all the Blue Crosses across the country, but also having a strong corporate leadership team. Andrew came from Sutter, the Advanced Illness Management Program. Jay Ben used to run a health plan for United and also ran a large home health company. But the most important part of what we're doing is really the clinical leadership. And so we really have been extremely fortunate to recruit amazing clinicians like Martha Twaddles leading our practice in Illinois, David McGrew in Florida, Janet Bull. You know, Martha and David were both presidents of the American Academy of Hospice and Palliative Medicine. Janet was the only site to win one of the CMI Round 2 innovation grants. And so we've just had these amazing clinicians. And I think what's really making it all click is having amazing clinicians with deep relationships on the ground, combined with really good systems and processes that can help those clinicians be successful in a scalable way, and in a way that can help guarantee and ensure the return on investment for the health plan so that they're willing to make the investment in these types of programs. And so with that, I will bring our presentation to a close, but thank you guys for letting us be a part of it.
Thank you so much, Brad and Dr. Lasher, for sharing your approach, and we look forward to seeing the continued expansion of your efforts, especially given the promising outcomes you just shared with us. I also would like to thank Dr. Frist for his leadership and for sharing his perspective with us today. Our next speaker is Dr. Diane Meyer. She's director of the Center to Advance Palliative Care, a national organization devoted to increasing the number and quality of palliative care programs in the United States. She's also vice chair for public policy and professor of geriatrics and palliative medicine, the Catherine Geisman Professor of Medical Ethics, and she was the founder and director of the Hertzberg Palliative Care Institute, all at the Icahn School of Medicine at Mount Sinai in New York City. She's an internationally recognized expert on palliative care, and under her leadership, the number of programs in the U.S. hospitals has more than tripled in the last 10 years. We're so fortunate to have her with us today, and I will now turn it over to her.
Thank you so much, Catherine. I can't tell you, Senator Frist, and your colleagues, how gratifying it is to me after working in this field for almost 20 years to know that a leader of your caliber is committing your time and resources to advancing access to palliative care. In a way, it makes me feel like I can declare victory and go home. What I want to review is the objectives. Why do we need palliative care? What is it? And to show you some more examples of clinicians and payers leading change. Obviously, you've just heard a superb example of a very recent initiative from Aspire Health that I hope will scale and replicate broadly. So Senator Frist mentioned this concentration of risk, and this just shows a little bit more detail about this, that actually 1% of the sickest Medicare beneficiaries account for 22% of spending, and you can actually see the dollars are a bit higher than the numbers that the senator showed. These are more current data. The 1% spend about $90,000 a year, the 5% around $41,000 a year, and the 10% about $27,000 a year, as compared to a much lower level at around $8,000 for your average, not very sick Medicare beneficiary. And what this does is create the identification of the target population who is both in need of much higher quality care, and because that is not available, ends up using 911, the emergency room, and the hospital to manage their illness. This is an actual patient of mine, Mr. and Mrs. B. They live at 92nd and York in New York City. They're real characters. You can see that Mrs. B makes all her own clothes, and she always sews a matching tie for Mr. B. This is your typical Manhattan patient. When I met him, it was 2 years ago in the emergency department at Mount Sinai. At that time, he was 88 years old with some dementia, but he came to the emergency department because of very severe back pain that was due to spinal stenosis and arthritis. He described his pain as 8 or 9 out of 10 and was taking potentially toxic doses of Tylenol, which is all his primary physician had told him to take, with no benefit. As it turned out, we got called to the emergency department, the palliative care team, by the ER attending, because this was the 4th ED visit for this couple in the prior 2 months, and you can see the reasons. Twice before for pain, weight loss and falls, and once for agitation and confusion for constipation and fecal impaction. His sole caregiver is his 83-year-old wife. Their only daughter lives in California. They are not in a doorman building, and they don't have anybody to call after hours when there's a problem. Mr. B wanted nothing to do with us. He had been in the ER and the hospital 3 times before in the prior 2 months. He was furious at his wife for calling 911, but this is what she said to us. He hates being in the hospital, but what could I do? The pain was terrible, and I couldn't reach the doctor. So this occurred on a Thursday evening at around 6:15. Mr. B was unable to get up off the toilet because of back pain, and she tried to help pull him up, and he fell on the floor, and she couldn't get him up. She called the primary care doctor, who happens to be a cardiologist, and they got a tape. And the tape said, if this is a medical emergency, hang up now and call 911. So she did exactly as the system was designed for her to do and called 911. And as she said, I called the ambulance. It was the only thing I could do. Now, let me tell you the rest of the story, because what we did on the palliative care team was prescribe really low doses of concentrated liquid oral morphine, a very aggressive bowel regimen, connect him to a house calls program very similar to what you heard described from Aspire Health that we have here at Mount Sinai, that has its own 24/7 coverage and 24/7 phone number so that patients never have to call 911 again. We also connected them to Meals on Wheels to try to reduce the cooking, shopping, cleaning burden on Mrs. B. And we connected them to a friendly visitor program that was run by their church that they hadn't been able to get to because of Mr. B's back pain. So they're basically high school students on community service hanging out with Mr. B 3 afternoons a week after school, giving Mrs. B a break. Now, that was 2 years ago. And Mr. B has not once been back to the emergency room or hospitalized, and they're doing fine. Would I have been not surprised if he had died shortly after I first met him? No, I wouldn't have been surprised. But actually, here he is, and they're both remaining independent in the community with the level of support I described. And that's why I want to show you this graphic. Many people believe that the costliest 5% of patients are predominantly people in the last 12 months of life. But as you see on this graphic, it's more complicated than that. And you'll be able to find detail about this graph in the about to be released new Institute of Medicine report about care at the end of life in one of the commission papers. We asked these researchers to look at the degree of overlap between being in the last 12 months of life and being in the highest cost, 5%. And actually the overlap is only 11%. That is, only 11% of the costliest 5% in retrospect turn out to have been in the last 12 months of life. About half of this group has short-term high costs from, say, an aortic valve replacement or a coronary artery bypass grafting or a bone marrow transplant, but their costs regress back down to the baseline after that year is over. That's not a group you can intervene on particularly because they're benefiting from modern medical care and recovering and going back to a decent function and quality of life. But the other half of the group, the 11% in the last 12 months of life, and the 40% who are high cost year after year after year. This is the group that benefits from targeting and screening for palliative care interventions and long-term palliative care support. And I think if you think about Mr. B, who is now getting long-term palliative care support, he's not dying, he's not hospice eligible, he's doing pretty well. There's a safety net around him that enables that to occur, most importantly, that 24/7 phone access. But if you look at prognosis and look solely at prognosis as your basis for eligibility, you'd be missing people like Mr. B. So what we have is very high acute care spending in patients like Mr. B who have multiple chronic conditions, functional or cognitive impairment, frailty, and high caregiver burden because of the misaligned incentives that Senator Frist described. And people like Senator Frist and his team are doing something about this by improving access to high-quality palliative care. And I want you to look at this definition because it was developed in consultation with members of the public through public opinion polling about what to the public is valuable about palliative care. And I think the first thing that you will note is that you will not see the word death, dying, terminal, prognosis, hospice, end of life anywhere in this definition. Patients and families are not in the market for a good death. They're in the market for a good life. And what palliative care tries to do is say we got a lot of people with chronic complex illness in the United States now thanks to the successes of modern medicine. How can we make those added years worth having? And so this definition here has really become the standard definition in the field for palliative care. It's about serious illness, not terminal illness. The term advanced illness is also problematic for the public. Most people among the public see advanced illness as terminal. They are much more accepting of the term serious illness. Its goal is to provide relief from distress, practical, physical, emotional, to improve quality of life for both the patient and very, very importantly, the all-important family caregiver, and should be delivered from the point of diagnosis in a serious illness and at the same time as regular disease treatment, not as the consolation prize for when there's nothing more that we can do. And Senator Frist showed a similar slide where palliative care is delivered from the point of diagnosis at the same time as disease-directed therapy, with the nature and ratio of those two approaches to care varying depending on the timing, the specific needs of the patient and the family. But I think the key point about this slide is the titration, the dose titration. That for Mr. B, most of the time, all he has is the 24/7 access to the Meals on Wheels and the friendly visitors, because most of the time he's stable. But the minute he is unstable, we can dose up right away, immediately, because of that 24/7 phone number and send a clinician to the house. And that is what averts the 911 calls and the hospitalizations. So as was mentioned before, there's now a pretty substantial body of scientific evidence showing that palliative care models improve value, and the quality outcomes that improve are listed on the left. And the consequences in terms of cost reductions are listed on the right. And I think the very critical point here that I cannot reiterate enough is that you will not get the cost reduction unless you deliver better quality. So think about Mr. B. Unless there was the ability to keep him from needing to call 911, from never getting a tape that says if this is a medical emergency, call 911, the consequence would be high cost. So the great thing about palliative care programs is if they are not really high quality and delivering standardized guideline-based palliative care as the ASPIRE program is doing, it will not achieve the cost reduction. And so the cost reduction is an epiphenomenon of quality improvement. You already heard about this randomized controlled trial. That was published in the New England Journal of Medicine, and this was office-based cancer care, palliative care, simultaneous palliative care with best cancer care at Mass General Hospital. This is the study that you saw from Kaiser, and I think the important thing to point out about this is these were patients with heart failure, COPD, and cancer who got regular Medicare home care. And you guys probably are aware that the eligibility criteria for regular Medicare home care are the patient has to both be homebound and to have a skilled need. And the minute they no longer have a skilled need, they are discharged into the open arms of their primary doctor's instruction to call 911 if there's an emergency. This huge gap between what the Certified Home Health Agency does and what hospice does is the gap that these palliative care models are trying to meet. And I think what you see here, and as was mentioned, this is Kaiser Permanente, which is a staff model, globally budgeted HMO, is that because they could see the impact on spending in all the other silos of care, they were willing to spend 3 times more money on the palliative home care because they couldn't afford not to once they looked at the downstream impact on hospital, ICU, skilled nursing facility, ERs, and doctor specialist visits. Interestingly, the New Yorker in 2013, in their innovation issue, had an article about integration of palliative care in nursing homes, which I commend to you. It's a wonderful article. And what's so fascinating about this is that all they did was shift the bias in the nursing home away from making everyone follow the same rules. Everyone has breakfast at 7 a.m., lunch at noon, dinner at 5, everyone is bathed a certain number of times a week. They shifted it 180 degrees and basically put the patient in control of their day. So if you want to sleep all day and eat peanut butter and jelly sandwiches at 3 in the morning, no problem. If one of their residents becomes agitated, the initial assumption is that it's pain rather than dementia-driven behavior. So they treat preemptively for pain when dementia patients become agitated or start screaming or moaning. And what they find is dramatic drops in turnover of staff in the nursing home and dramatic improvement in resident well-being and family satisfaction and dramatic reductions in use of the hospital. Now, in Washington, in the Beltway, there's a great deal of anxiety about talking about palliative care, and everyone knows what the reason for this is. But actually, when you ask the public, and this is, again, public opinion research that we did with Public Opinion Strategies, Bill McInturf in Washington a couple of years ago, patients and families, the public, overwhelmingly, more than 90%, say they want this kind of care when it is defined the way I showed you earlier. So here's where we are now. The typical pattern, ED hospital, home, no support, call 911, ED hospital, ICU, and the lucky ones get hospice usually for a week or less at the very end. But as Senator Frist pointed out, the real cutting-edge activity in our field now is in the private sector. And this is just a few examples of what creative, innovative payers across the country are doing. This is not fee-for-service Medicare that's doing this work. This is commercial payers. And here's just one example, Randy Krakauer's Compassionate Care Initiative. A couple of quotes from him. Reading case manager's notes dramatically illustrates the need for this assistance, the too common absence of such assistance, and the almost desperate gratitude this engenders. We have dedicated ourselves to providing this help. And then I love this quote from the Wall Street Journal. If there is an opportunity to impact at the intersection of quality and cost, this, meaning palliative care, is the mother lode. And here are their data. This is a focus on about 1% of their Medicare Advantage members. They had an 82% hospice election rate, an 81% drop in hospital days, an 86% drop in ICU days, very high member and family satisfaction, and the letters of appreciation to the payer, not to the doctors, but to the payer, from families are quite moving, actually, and a total cost reduction of over $12,000 per member. Highmark Blue Cross Blue Shield in Western Pennsylvania has developed a series of programs led by Judy Black, and she's quoted as saying, studies show that people with palliative care and the opportunity to discuss their treatment goals actually live longer and have a higher quality of life. This is really about a community effort. It really is about linking palliative care expertise to primary care and to community providers like nursing homes, hospices, home care agencies, aging services, Meals on Wheels, transportation. And these are Highmark's data, again, very high satisfaction, again, nearly 80% hospice election rate, roughly double the median length of stay in hospice, and marked reductions in acute care utilization. So my organization, the Center to Advance Palliative Care, actually spent a year and a half doing an environmental scan of what payers around the country are doing. This was led by our policy analyst here, Emily Warner, and a consultant, Tom Gualtieri-Reed. This toolkit is downloadable for free. It basically looks at the structure and process characteristics of palliative care programs that reliably deliver on better quality, and as a consequence of better quality, lower cost. And I encourage you to take a look at it. And that's the end of my remarks. Thank you.
Thank you so much, Dr. Meyer, both for your leadership in the field and also for sharing with us today a little bit how payers can work with providers to deliver palliative care. Our last speakers will delve more deeply into an example of how a health plan is collaborating to increase the availability of palliative services in Illinois. And we're joined by Opella Ernest, who is the Chief Medical Officer for Blue Cross Blue Shield of Illinois, and Dr. Cale Wilhot, Senior Medical Director, Quality and Outcomes, also at Blue Cross and Blue Shield of Illinois.
Thank you.
Dr. Ernest?
Thank you. Good afternoon. On behalf of Blue Cross Blue Shield of Illinois and our parent company, Healthcare Service Corporation, I'd like to thank the National Institute for Healthcare Management for inviting us into today's discussion. Blue Cross and Blue Shield of Illinois is the largest healthcare insurance company in Illinois. We have a local presence and focus really since 1936. Our local focus helps us develop strong relationships with other organizations, which has been beneficial historically, and is even more important as healthcare evolves at a rapid pace. We know that collaboration is key. None of us can go it alone in the new world. With respect to palliative care, we aren't seeking to be experts in palliative care, but we do want to help our provider partners, who we consider to be the experts, improve access to coordinated, high-quality palliative care. We all have different roles to play in a partnership, and we found that as a payer, we could help remove the cost barriers to improve access. So now you'll hear from Dr. Carol Wilhot about how Blue Cross and Blue Shield of Illinois and our hospital partners collaborated to improve access. Carol?
Good afternoon. In 2010, we began to focus on the problem of readmissions. Knowing that we could not address this issue in isolation, we partnered with other entities that had diverse strengths. The Illinois Hospital Association had strong relationships with hospitals. The Feinberg School of Medicine at Northwestern University had expertise and experience in care transitions and in palliative care. We had funding available for community-based activities. So collectively, we formed an entity called PREP, Preventing Readmissions Through Effective Partnerships, and through PREP have implemented a variety of programs, including some directed at palliative care. The key initiatives of PREP were to improve transitions of care, redesign hospital discharge processes, increase the focus on palliative care, strengthen hospitalist programs, and provide hospitals with standardized metrics related to readmissions. With respect to palliative care, which is really our focus today, our palliative care initiative was titled Communication and Palliative Care, or CPC for short, to emphasize the need for communication with patients about their goals of care. The CPC program aims to identify patients and implement timely communication, timely documentation and coordination, and also to enhance the delivery of patient-centered care that was consistent with the patient's own goals of care. Through the CPC programs, hospitals that were involved in the program learned key communication skills. They developed protocols to identify appropriate patients for goals of care conversations. They implemented standardized approaches for documenting patients' goals and wishes. And they collaborated with a palliative care physician mentor that was assigned to each hospital involved in the program to help them implement their program and execute a successful QI project. The CPC program was organized around several specific activities. First of all, hospitals enrolled in CPC came to Northwestern University for a 2-day interactive training with professional actors that assisted the participant teams from the hospitals in learning how to communicate with patients about their goals of care. And they learned how to have difficult conversations and became much more comfortable in actually talking to patients because they had experience in doing it through this educational program. Each hospital that participated in the program had an external physician mentor assisting the hospital in implementing their program. The physician mentor was involved in coaching, in site visits, and involving community connections, and helping interpret data, and then a whole range of activities that took place throughout the year. And then at the end of the 1-year program, the participating hospitals met for a reunion and shared their experience and were able to learn from each other. Our experience with some of the other programs of PrEP, apart from palliative care, including Project Boost, made us aware of the value of an external physician mentor to assist hospitals in developing and implementing new programs. Project Boost was recognized in 2011 with the John M. Eisenberg Patient Safety and Quality Award for their physician mentor program. And this was really considered to be the secret sauce that made Project Boost effective. Therefore, based on our experience with Project Boost, based on that national recognition, we decided to include a physician mentor in many of our other PrEP programs, including the Communication and Palliative Care program. The one challenge for hospitals in implementing a program, particularly one that involves a physician mentor, is that there are costs involved in such a program. And so in order to remove the barriers to participation, BCBSIL expanded its existing hospital bonus program to cover the fees. Each hospital is still responsible for contracting with and paying the entity offering the particular program, such as the Communication and Palliative Care program, but we removed the cost barrier to make it easy for the hospital to participate. The Feinberg School of Medicine provided the clinical leadership and expertise. They provided many of the mentors and recruited other mentors as well, so that each hospital participant did have a mentor. In terms of results of the program, over the past 3 or 4 years, 29 hospitals in Illinois in 6 separate cohorts have participated and are near to completion or have completed the PrEP Communication and Palliative Care program. Through this program, there have been 127 participants who completed the program. The participants represent a range of disciplines, including physicians, nurses, social workers, and chaplains. Each hospital has implemented at least one creative program to address and implement palliative care in their own hospital and in their own communities. The feedback that we've received has been very positive, and particularly at the reunions at the end of the experience, there have been some really great stories, and I thought you might be interested in hearing some of those. At one of the reunions, a nun from one of the Catholic hospitals that participated in the program stated that she finally knows how to talk with patients about their goals of care. While she had spent her entire career working as a chaplain in the hospital setting, she really had never been comfortable with that aspect of her position. She had found this program particularly beneficial as she addressed the spiritual needs of patients. Another example is a team member from one hospital with a family physician who was also ordained as a minister. He became so engaged in the program that with the support of his hospital system, He moved from another part of the state to Chicago for a year of palliative care fellowship. He then returned to his hospital to expand the palliative care services available within the hospital and within the hospital system. On another scale, but a very concrete example, at one of the reunions, we heard about an elderly man with end-stage COPD who had been identified for the goals of care conversation because the hospital was screening people who met their target criteria for screening. He had had many hospital readmissions because of his disease. When somebody took the time to talk and understand his desires, his real goal was to sit on his deck and enjoy his backyard. Knowing that, his medical team was able to manage his care in a way that kept him at home and out of the hospital for his remaining days. And one hospital reported at the reunion that they had provided education about palliative care in their community. Deciding to choose a non-threatening setting, they participated in a community farmers market and provided education in that non-traditional setting that really got the hospital out into the community. Through this program, we've learned a number of lessons. First of all, there's a need for early senior leadership buy-in at hospitals. Certainly, physician engagement at the local level is absolutely essential for a program to succeed. We felt that even though the program we implemented had really good hands-on education up front, there was a need for better educational resources. There was certainly identified a need for coordination across sites of care within a healthcare system or community, and also better data infrastructure and quality improvement support. With that background, we're considering our next steps as we come to the end of the 4th year of this particular program. We're currently considering expanding this palliative care program for hospitals to be 3 years in length, requiring early executive sponsorship, a physician champion, very active involvement of inpatient teams, but also a team or two from local skilled nursing facilities that interact with the hospital to really expand the continuum of care over which the hospital implements its program. There's consideration of expanding the educational program to include online education, adding standardized metrics, the standardized screening tool to identify patients for goals of care conversations, increased use of POLST, and as I mentioned earlier, engaging post-acute care partners. While Blue Cross Blue Shield of Illinois does not directly provide patient care, we can facilitate opportunities and reduce barriers for providers in our network so that they can improve the quality of the care that they provide.
Thank you both so much for sharing your collaboration and your success integrating palliative care across many Illinois hospitals. There's a lot of interest in learning from everyone's experience that's with us today, and we're excited to engage now in a Q&A session with our audience of healthcare decision makers from policy, business, government, as well as healthcare providers, both in the medical and the palliative care community. At this time, I'd like to ask our operator to explain how you can ask a question if you're joining us by phone, and at any time you can submit a question through the web console.
I'll now turn the call back over to Ms. Santoro. Please go ahead.
Thank you. We have a question for Brad and for Dr. Lasher. I'm going to combine a couple questions together. One, you mentioned, working with leading physicians, and that really helps with engaging patients. We had a question if there, any other ways of how you are motivating patients to engage with Aspire. And also along those lines, within your model, how are you helping to take care of the caregivers in addition to the patients themselves?
Yeah, well, this is Brett. Why don't I, Andrew, take a shot at how we're identifying and engaging the patients, and let you take the caregiver part. What we have found to be most effective for engaging the patients is to have someone who knows the patient either help introduce us to the patient or refer us to the patient. There's a lot of ways that that can work when we're running co-located oncology practices. A lot of the times that is an oncologist, or it might be one of the nurses or care coordinators in the oncology group. When we're working with highly organized PCPs, so think sort of IPAs, MSOs, patient-centered medical home type structures, a lot of times we're able to present to the PCPs, and the PCPs or their nurses end up talking with the patients about it. Other times, think of Medicaid programs where health plans have obligations to send social workers or others to the home. Sometimes it's the social worker or the person from the health plan introducing us. And there are a few times when we're reaching out to the patient directly, but we're very focused on having someone who's close to the patient be able to reach out to them and introduce our program and our services. Andrew, do you want to take the caregiver piece?
Sure. I mean, anybody who works with this population knows that the strain on caregivers is enormous, physically and emotionally. A lot of what our social worker role, both office-based and at the encounter level, is to take care of these people, to connect them with resources, to be a resource for the caregiver, not just the patient. I would say the same thing about our chaplaincy role. So, I would also extend it, for that matter, to bereavement, for the caregiver that's left behind after a patient's passed away. So, a lot of the work that we do is to try to help connect people with resources in addition to providing the in-person support to a caregiver in need.
Great, thank you. We have another question for Aspire before I check in with the operator. One of the participants was curious who they should contact at Aspire if they're interested in working with you all.
If they're a physician, they can this is Brad, they can contact me, or a health plan, they can contact me. My email address is bsmith@aspirehealthcare.com, or you can go on our website, aspirehealthcare.com. There's a contact us form, but they can just email me directly and I'll follow up with them.
Great, thank you. John, do we have any questions in the queue?
Yes, thank you. We do have a question here from Jan Grimes. Please go ahead.
Hi, folks. Great session. I am the Executive Director of the Illinois Home Care and Hospice Council, and our association is working closely right now with the Illinois Hospital Association, and very well aware, of course, of the great work of Blue Cross Blue Shield. We have a grant, and I invite you to pay attention in the coming months, to offer a massive open online course, which will be free globally, and which will be called One Patient, One Team, the Palliative Care Across the Continuum. And we've got a national grant because our small home care and hospice association, really wants to be players in this. We've been understanding outside the hospital walls the important part that home care plays in reducing readmissions, but also introducing palliative care. I wonder from the panelists about your perceptions of the inclusion of home care in the planning here and how home care agencies might help.
Absolutely. Andrew, do you want to talk about how we work with home care?
Sure. I mean, one of the big misconceptions that physicians have is that we replace home care, or that you cannot have both an Aspire provider and home care. And the beauty of being a physician practice is that these things can coexist really well. So on a patient level, it's really important that when we're involved and home care is involved for physical therapy or wound care or whatever issue they're there for, that we have a straight line of communication between our nurse practitioner and the nurse that's providing home care or whatever provider there is. On a larger level, you can imagine from the standpoint of working with health plans, we really do want to make sure that we're working with the highest quality home care agencies, that we are stewarding their resources. We're often the ones that are helping arrange home care, and we want to make sure that we're doing that in the right situations with an eye on cost and quality both. So it's really important for us in every market that we're in to identify home care providers that are really good and who are good communicators and willing to work with us. So I think that pretty much summarizes it.
And the only thing I'd add to that, Andrew, is that we found that responsiveness is really important because really, like Dr. Meyer said, a lot of this is about building a relationship with a patient, but really having them call you in a crisis. And so a lot of the times, whether it's we need home care to go out and follow up on something, or if we're transitioning patients to hospice, for example, a lot of our hospice transitions actually happen at night or on the weekend when people are calling in with crises. And so having a hospice who not only, is, quote, 24/7, but really can admit a patient 24/7 as a partner has been really important in the markets we're working.
I would strongly agree with that. I mean, whether it's hospice, whether it's home care, whether it's home infusion, the ability to have not just the communication but the quick response time is really critical to being able to provide what we say we'll provide and help keep folks out of the hospital when they don't need to be there.
This is Diane Meyer. We call that in my office meaningful response. Like if the 24/7 number is useless, if somebody leaves a message and nobody calls back for 2 hours, that leads to a 911 call. I think the big challenge nationally in the existing boots on the ground in the community are certified home health agencies and hospices. And both of those entities are looking to see how they can fill this huge gap for community-based palliative care and are stepping into that space. And I think that's great, but I have concerns because neither hospice staff nor home care staff are actually trained in palliative care. And in fact, home care nurses are typically trained that if a patient calls and says, I'm short of breath or I'm in pain, they actually tell the patient to call 911. They are not trained to address complex symptoms in the home. They are not trained to have goals of care discussions. They are not trained to coordinate care with community partners and across settings, and they're certainly not trained to provide the 24/7 support that is the key to improving quality and reducing costs. So could they be so trained? Absolutely, but it really means a culture change and an investment in workforce training in the home care workforce. And similarly on the hospice side, hospice staff are really good at taking care of people who are close to death, whose goals are to have a peaceful, comfortable death. That's a very small fraction of the high-risk population. Most of the high-risk, high-cost population is not dying and needs both life-prolonging disease treatment and palliative treatment at the same time. And most of the hospice workers I know and have worked with are really not comfortable in that space. And that requires, again, training and a different set of expectations and metrics for those staff. And I think that somebody needs to invest in a real fundamental workforce reboot for the staff that are already in the community that have really not been able to respond to this need because of Medicare statute that limits them to very narrow slices of the need.
Thank you. John, are there any more questions on the phone?
At this time, we have no further questions on the phone lines. However, if you do have any questions at any time, you may press *1 on your touch-tone phone.
Great. Well, I'll move to some additional questions that have been submitted via the web. One question, and Diane, you touched on some of the public opinion polling that you've done, and the increasing acceptance and want for palliative care. This question is, how do we help seniors and others understand the cost of palliative care? And some seniors are concerned, is this an additional expense? How do I afford this? And could any of the speakers talk a little bit about some of the efforts to help with the cost?
The short answer is it's covered by their regular insurance, and it's not an added cost for patients and families. So, I mean, that's the nub of the content. This is paid for through either Medicare Part B fee-for-service reimbursement for physicians and nurse practitioners, through hospital or health system operations dollars for the elements of the palliative care team that is not compensated by fee-for-service billing, and increasingly, as Senator Frist and his team described, through risk-bearing models, either payers or ACOs and other integrated health systems that are supporting palliative care through their operations dollars because they can't afford not to.
Great, thank you. A question for Carol. Could you speak to the strategy and tactics that you use in engaging and winning hospital leadership to join in your efforts?
Well, because we had partnered with Northwestern University and also with the Illinois Hospital Association, they really had a lot of the contacts at the hospitals, had good relationships with the hospitals, and so on. And we also interact a lot with the hospitals through our network area as well. So collectively, you know, between the three entities, we had relationships. We had the academic support and the subject matter expertise support to answer questions from hospitals. And, you know, so that's where working as a team really made a difference in working with hospitals, addressing their concerns. And for the most part, demand was very high and didn't take a lot of recruitment for this particular program.
Great, thank you. Diane, you touched on a little bit about palliative care in the nursing home, and we had a question specific to Aspire, but anyone could comment. This woman is a geriatric nurse practitioner, and she's wondering how this type of model could be adapted for the nursing home population, realizing that it has its own billing challenges.
I'm happy to talk about that, but any of my colleagues, go ahead.
No, take a shot at it, Dr. Meyer. That sounds great.
Okay, so the Center to Advance Palliative Care is developing tools and technical assistance for palliative care delivery beyond hospitals, and one of the most important settings we're going to be focusing on is the nursing home. Talk about a very high-risk, vulnerable population. Nursing homes are the mother lode for that. And there are a number of different models that we've identified that nursing homes are using, and as Senator Frist pointed out, unfortunately the financial incentives militate against the adoption of those models in nursing homes. I'm hoping that ACOs, 30-day readmission penalties, hospital mortality penalties will drive hospitals and health systems to help support the services that are needed in nursing homes. They need money and staff to be able to support their residents without sending them to the emergency room. But the models range from bringing in outside consultants, such as advanced practice nurses, to provide palliative care consultation billed under Part B within the nursing home. That's being done at the Palliative Care Center of the Bluegrass in Lexington, Kentucky, and other places. A second model is training a team within the nursing home to provide internal palliative care, and that may be just taking a medical director, several nurses, several social workers, and sending them for specific training, and essentially having an on-site level of expertise combined with checklists and identification of residents who have high needs. And then the third model is integration of hospice services within the nursing home, not necessarily delivering Medicare reimbursed, Medicare hospice benefit services, but the data show that the better integrated hospice is in a nursing home, the higher the quality of palliative care across the entire institution, including patients who are not on the Medicare hospice benefit. So it probably has to do with upskilling the nursing home staff and making people understand that you can treat pain in people in a nursing home, and it's safe to do that, and that there are ways to do things that will relieve suffering that don't require you sending someone to the hospital.
Thank you, Dr. Meyer. Another question we had is asking the panel to share their thoughts on the role of palliative care for those patients who were under the age of Medicare, not receiving Medicare, but living with advanced illness, there's horrific comorbidities, there's symptom burden, spiritual, emotional distress, sometimes made worse by psychosocial issues, and also kind of how you, working with that population as well as how you integrate with mental health providers into the care team.
Andrew, do you want to take that one from the Aspire side?
Sure. I mean, we are working with a range of patients, although our primary customers have been Medicare Advantage. We have in a number of our markets a large dual population, where we're seeing great gaps in health literacy, and patient engagement, and that's been true everywhere we've worked. In many ways, it involves us increasing the frequency of our visits or changing the composition of our teams or the ratio of our touch, increasing social work involvement in some places, or building our own behavioral health component is eventually where it's likely going to need to go with a team of trained behavioralists, basically. So I think that's the start of it. I don't know if anybody else wants to add to that, but I think we're very aware of the different needs that this population, this very variable population has, and how to address them in a palliative care context when people are both medically sick but financially or behavioral health-wise challenged is a real problem, and we know it.
Thank you. Diane or others want to comment on that question?
Again, want to draw your attention to the Institute of Medicine report that will be released on September 17th because it calls for, as a standard of care, the integration of social and behavioral health with medical services in this complex population. The data suggests, particularly in duals populations and other specific groups, that about 50% of the high users in that thickest 5% are using either because of mental illness or social determinants, like they don't have transportation, or they don't speak English, or they have limited literacy, or there's major family conflict. There are reasons that have nothing to do with the caliber of medical care that are driving dependency on 911 calls. And if we don't, first of all, identify those issues, and secondly, have the skill to act on them, we will not have any impact on either quality or cost. So what Aspire is talking about, which is pulling in the members of the team with the expertise and the capability to do something about those problems. Like, for example, we had a patient who was living in a four-story walk-up, and who had a son living with her who was an alcoholic, stealing her Social Security check, and abusive. And it was the social worker that found safe senior housing for our patient and immediately dropped her 911 calls, ER visits, and hospitalizations dramatically. So you can't separate them. And I think it's the separation that's embedded in Medicare statute that has put us in the mess that we're in right now.
And certainly the issues that lead to palliative care, or the need for palliative care, don't go away with age, or aren't based on age. It's certainly relevant at all ages.
Yeah.
Great, thank you. As we approach the end of the Q&A, I did want to give each of our speakers a few seconds to offer any of their closing thoughts, or to perhaps to offer, what's one key thing that you think needs to happen to increase access to integrated palliative care, or what would be helpful to your work going forward. Let's maybe start with Aspire and go down the line.
Sure. Well, the first thing I'd like to say is just thank you to Dr. Meyer for all the work that she's done in this field, because really way that we're being able to scale is only because of all the work that she has done in helping train and place palliative care physicians in all these places across the country. I'd say for us, the biggest policy issue is we're having lots of success with Medicare Advantage, duals, commercial health plans, but for Medicare fee-for-service, that still represents the vast majority of the patients that need this kind of service. And so I hope over time that there's some solution that allows these kind of programs to be extended to those patients as well, because we can't go to a hospital now and take all of their palliative care patients because we only have a few payers in each market that we're working with. So, so that would be my big one.
Dr. Meyer?
Yeah, so I think the Aspire model is fantastic because it scales the very scarce palliative care specialty expertise much more broadly. But this is a huge challenge, that there is nowhere near enough specialist-trained physician, nursing, or social work workforce in palliative medicine to even begin to scrape the surface of the need in this country, particularly with the aging of the baby boomers that is upon us, me and Dr. Frist. And I think that we've got to really invest in what we inside the field call generalist training, meaning that every clinician, whether nurse, social worker, physician, chaplain, who touches seriously ill people, so that would be a family practitioner, a pediatrician, a neurologist, an oncologist, a cardiologist, needs to have core training and demonstrated competencies in really basic stuff like pain and symptom management and communicating about what matters most to patients and families. And as shocking as it is to the general public, most of us have had zero training in any of those skills. And that explains a lot of the failures in the current health system. We physicians practice as we are trained, and we are not trained to deliver the core competencies of palliative care. So we'll be launching an online training curriculum that will cover both symptoms and communication on January 1st that people can do on their iPhone or their iPad or while waiting for the subway, that will be linked to CEU and CME credits in an attempt to try to raise all boats so that all patients can see clinicians with at least a decent minimum of knowledge and skill.
Great, thank you. Dr. Ernest and Wilhoit?
Sure. You know, as we continue our transition from fee-for-service to value-based care, we would just like to, again, restate we're looking for opportunities and want to be very much a part of collaborations to improve the care and to support the models that were discussed by everyone here. So that would be my closing comment. Carol?
And I would say that just as our patients live in communities and families have complex interactions, you know, they're not unidimensional. This really requires teamwork and a lot of us working together in various ways for the benefit of the patients we're responsible for.
Great. Well, thank you all so much for being with us today, and we truly hope that given our audience today and the many examples of opportunities to overcome barriers to integrated palliative care that have been highlighted, that we make real progress in the months and years ahead. We appreciate everyone for joining us and hope that you'll email us to share feedback from the event, and we'll have a recording with slides and audio available on our website for you to share with your colleagues shortly. So thank you all again so much.